Have you ever been embarrassed that you couldn't get a lower molar completely numb during a treatment? If so, today's video is a must-watch as I unveil my tiered approach to mandibular anesthesia that guarantees success every time, even on those abscessed molars. Hi there, I'm Dr. Schick, a general dentist passionate about sharing knowledge and expertise through the educational profile, The Educated Associate, with the aim to support dental professionals in any form of practice. Let's dive into the details of my tiered approach to achieving profound anesthesia for a mandibular molar, starting obviously with tier number 1, the standard local anesthesia techniques. Tier number 1 serves as the foundation for successful anesthesia. I always begin with some topical anesthetic jelly, such as 20% topical benzocaine. To do this properly, first dry the injection site with a 2x2. Then apply a benzocaine-coated tip on a cotton tip applicator to the injection site to numb the surface tissues and minimize the discomfort the patient will experience during needle insertion. In this case, we are talking about the area kind of in the cheek, just above the pterygomandibular raphe. So use your 2x2, dry that, and then put your cotton tip applicator with benzocaine right there. The real trick is, once you put the cotton tip with the gel in its spot, you should cover the area back up with your 2x2 that you already used to dry the area. Covering up the gel with the 2x2 has two benefits. Number 1, it helps to make the area stay dry, better absorption of the benzocaine into the tissues. Number 2, it prevents the benzocaine from dissolving and oozing out into the rest of their mouth, causing that foul taste associated with that medicine. Next, proceed with a standard inferior alveolar nerve block, which will anesthetize the inferior alveolar as well as lingual nerves. I always step up this standard technique by aiming a little bit higher above the pterygomandibular raphe. Instead of aiming just above the raphe, on my second shot, I'll always aim really high, just beneath the maxillary tuberosity. Kind of feels like a Gaugates block if you've ever learned one of those. For my IA injections, I always use warmed 2% lidocaine. So I always start with 2 carpules in the IA technique I just described. I'll then set the patient up and let gravity and time do their things. After 5 minutes of the medicine soaking in, if the patient isn't fully numb, I'll move forward with a buccal infiltration to complement the IA I just gave. To do this, I'll infiltrate near the mandibular molar in question. This obviously targets the buccal nerve branches and it should enhance the anesthesia from the IA we already gave. The actual anesthetic I'll use in this injection is a goal of changing the pH in the environment, so I'll oftentimes start with some 4% septicaine. I'll warm it. Sometimes a little mepivacaine can help as well. So one of those or both of those as a buccal infiltration can really be helpful. If the patient isn't fully comfortable at this point, I'm going to move beyond my standard techniques and move to tier number 2, which are my supplemental techniques for inflammation. My next step is always to proceed with a PDL injection. The periodontal ligament injection obviously targets nerve endings in the PDL, and it should provide a very localized anesthesia to that one tooth. You should be ready to apply a pretty decent amount of pressure. It can sometimes take quite a bit of a squeeze to get any anesthetic into the PDL space. Typically, if I can get an 1/8 to a 1/2 a carpule into the PDL of the tooth in question, it can make a real big difference. I normally use a 27 gauge needle and 2% lidocaine for these injections, but really you can use the anesthetic of your choice. I've had really good luck with 2% lidocaine. The trick on these for your patient satisfaction is to make sure your assistant is there with the suction device. That way they're ready to suck up any of the anesthetic that unfortunately will ooze or squirt out of the PDL space. We all know how anesthetic tastes, so having the assistant ready to suction up the extra can really make it more pleasurable for your patient. So at this point, still in level 2, if the patient isn't fully numb, I move to non-anesthetic ways to help manage their pain. Ideally, the patient should have come in already having taken 600 milligrams of ibuprofen, so a preoperative NSAID can make a huge difference, as well as an intraoperative addition of nitrous oxide sedation. So by having them take like 600 milligrams of ibuprofen 2 hours before the surgery, that's going to have an anti-inflammatory effect, so take down some of the inflammation. It's also going to be an analgesic, so it's going to help with your pain management. By taking the NSAID before the treatment, you're going to enhance the anesthetics you already gave, and you're also going to help with pain management. For example, if I have a patient coming in, they call my front desk, they say that they're having some pain, they're maybe a little bit swollen. As long as they don't have any allergies, they're not renally impaired, I'll ask them to go ahead and take 600 milligrams of ibuprofen on the way in. Additionally, as mentioned, I tend to add some intraoperative nitrous oxide sedation. This can serve as both an anxiolytic as well as an analgesic, so you can help with patient comfort and the patient experience by adding this in. I found that nitrous oxide makes the patients much more relaxed. Personally, I've found that the addition of a preoperative 600 milligrams ibuprofen coupled with intraoperative nitrous oxide can really get even the most anxious patients through virtually any extraction. Key word there was extraction. Sometimes if you're actually drilling on the tooth, needing to do a crown or a root canal, you'll need to move to tier number 3, my advanced techniques. But in order to get a tooth comfortable enough to be extracted, typically tier 2 can get you there. So make sure you're using some NSAIDs, some nitrous oxide intraoperatively, and then the anesthetic techniques we already discussed. Now, unfortunately, if we're needing to do a root canal on a highly inflamed lower molar, sometimes we need to upgrade to tier number 3, the advanced techniques. Tier number 3 is my advanced technique for those highly resistant cases that I just can't quite get comfortable. And this is an injection into the floor of the mouth near the tooth in question. So in highly resistant cases, a floor of the mouth injection can provide anesthesia to the nerve to the mylohyoid. In some rare cases, the nerve to the mylohyoid can provide some sensory innervation to lower molars. So by getting some anesthetic to that nerve, you can hopefully anesthetize that nerve as well. And hopefully that's the tail end of the sensory fibers going into those teeth. I personally, again, resort to the floor and mouth injection as my last resort. It's a soup of vessels down there, and I really don't want to be causing any needle tract infections. So when I do these, I always get a brand new 30 gauge needle. I only use 2% lidocaine. I'll do the injection and then I'll get rid of that needle. So again, I want to avoid needle tract infections or cause a huge hematoma or something down there by using a big needle. So in summary, by adopting this tiered approach, starting with standard techniques and progressing to supplemental and, if needed, advanced techniques, dentists can effectively achieve profound anesthesia for even the most inflamed mandibular molars, and always avoiding that embarrassing moment of telling the patient that you have to refer them to a specialist because you couldn't get them numb. Stay tuned for more insights and tips to help you in your professional journey. If there's anything you would like to hear more about, please comment with that. Moreover, if you found this information helpful, please subscribe to my channel so that you never miss out on more valuable information down the road. And as always, stay drilling, my friends.